All right, welcome to our masterclass. Today, we are tackling a topic that is absolutely guaranteed to pop up in your exams, and honestly, you'll see it all the time in the emergency department, the radial head fracture. It seems common, right? But its management can be surprisingly tricky. So let's get right into it.
So, why are we starting here? Because you have to appreciate just how common this is. The radial head fracture is hands down the most frequent fracture of the adult elbow. We're talking about almost a third of all elbow injuries. So yeah, you are going to see this in your practice, and you are definitely going to be asked about it.
Okay, here's your classic Viva scenario. You've got a 35-year-old who took a tumble, fell on an outstretched hand, the classic foosh, and now they've got a painful elbow. The examiner leans forward and says, "Talk me through your approach." This is where you shine.
To absolutely nail that question, you need a rock-solid structure. So we're going to build our answer from the ground up. We'll kick things off with the anatomy and biomechanics, then get into diagnosis and classification. From there, it's all about treatment, weighing up fixation versus replacement, and then tackling those really complex injuries. And of course, we'll finish with a high-yield checklist to make sure you're totally prepped for exam day.
First up, anatomy and biomechanics. Look, to manage this fracture properly, you have got to understand the vital role the radial head plays in keeping the elbow stable. It's the foundation.
The number one thing to get here is that the radial head is way more than just a simple hinge. Yeah, of course, it lets the forearm rotate, but its main job, stability. It's a critical secondary stabilizer against valgus stress. That's force coming from the outside. And, super importantly, it's a key player in preventing posterolateral rotatory instability. Forgetting that stabilizing role is a huge mistake in any exam.
All right, Section 2, Diagnosis and Classification. This is where we take what we see in the clinic and turn it into a clear, actionable plan. The history is going to be your textbook foosh injury. When you examine them, you'll find tenderness right over that radial head on the outside of the elbow. Now, the key test is pain when you gently turn their forearm, pronation and supination. A big swollen joint or a mechanical block where they just can't move it, that's a red flag. But the most important step, and where so many people lose marks, is forgetting to check the joints above and below, the shoulder and especially the wrist. Don't be that person.
Now, you might look at a lateral x-ray and not even see a fracture line. But what you might see is this, the fat pad sign, sometimes called the sail sign. It's that little shadow of the anterior fat pad being pushed out. What does that tell you? There's fluid and effusion in the joint. And in an adult who's had trauma, an elbow effusion means a radial head fracture until you can prove it's not. It's a subtle clue, but it's a huge one.
Okay, time to classify this thing. We use the Mason system. Type 1 is simple, it's non-displaced, it's stable, so we're going to treat it without surgery. Type 2 is displaced, and the big question here is whether it's blocking movement. Type 3 is comminuted. The head's in a bunch of pieces, which makes it unstable. That's always going to be surgical. And then there's Type 4. The worst of the bunch. That's the fracture plus an elbow dislocation. It's super unstable and absolutely needs surgery.
Okay, Section 3, Treatment Principles. Now we take that classification and turn it into a solid game plan.
So here's the playbook. For a Type 1, the name of the game is early movement. A sling for a few days for comfort, maybe up to a week. Then you get them starting range of motion exercises right away to stop it from getting stiff. For a Type 2, with no block, same thing. But if there is a mechanical block, well, that piece needs to be fixed. For a Type 3, we're going to the operating room. The big debate then is, do we fix it with a plate and screws, or do we replace the whole thing?
Which brings us to Section 4, RIF versus arthroplasty. This is the critical debate for those really nasty fractures. It's a consultant-level decision, and you need to be able to back up your choice with some real evidence. So let's put them head-to-head. On one side, you have ORF, fixing it. This is great because it saves the patient's own anatomy, which is why we often prefer it in younger people with simpler breaks. The downside? The fixation can fail and the risk of stiffness is pretty high. Now on the other side, you have a radial head replacement. This is fantastic for giving you immediate stability when the head is just shattered beyond repair. And the data shows it often gives better functional scores and has fewer complications overall. But it has its own set of problems, like overstuffing the joint or the implant loosening over time.
And if you need a number to really hammer this point home, here it is. One major study found that for those complex Mason type 3 fractures, fixing it with ORF led to stiffness or arthritis in 24% of patients. With a replacement, that number drops all the way down to just 6%. That is a seriously powerful statistic to have ready for your Viva.
Moving on to Section 5, the complex injury. Recognizing these associated injuries, this is what separates a pass from a high pass. These are the high-stakes situations that you absolutely, positively cannot afford to miss.
First on the list, the terrible triad. And believe me, the name says it all. It's this perfect storm of 3 injuries happening at once: an elbow dislocation, a radial head fracture, and a fracture of the coronoid process of the ulna. This is a brutally unstable injury that used to have really terrible outcomes.
And second, the Essex-Lopresti fracture. This right here is exactly why I told you to examine the wrist. It's a radial head fracture plus a dislocation of the joint down at the wrist, all because the membrane connecting the 2 forearm bones has been torn. Missing this is an absolute disaster for the patient.
And if you find an Essex-Lopresti injury, this is the single most important rule you need to remember. You cannot just take out the broken radial head. You can't. The radial head acts like a spacer, a longitudinal stabilizer for the whole forearm. If you resect it, the entire radius bone will shift upwards, and that leads to horrible wrist problems. You have to either fix it or replace it, no exceptions.
Finally, let's wrap it all up. Section 6, your Viva checklist. We're going to boil everything down to the key buzzwords you need to say and the critical mistakes you have to avoid.
Okay, these are your golden phrases. You want to sound like a consultant? Use these. Call the radial head a critical secondary stabilizer. Describe the dislocation pattern as moving from lateral to medial. When you talk about plating it, mention the safe zone to show you're thinking about avoiding impingement. State very clearly that resection is contraindicated in any unstable elbow. And for the terrible triad, just list the steps. Fix the radial head, fix the coronoid, and repair the LCL.
And on the flip side, here are the traps. Do not forget to examine the wrist. Do not downplay a tiny coronoid fracture. It's a massive stabilizer. Never ever suggest taking out the radial head in an unstable elbow. Know the different complications for fixing versus replacing. And finally, always talk about getting that elbow moving early to prevent that horrible post-traumatic stiffness.
So to bring it all home, that really tough decision, do we fix it or do we replace it? It really just boils down to these 3 things. How shattered is the bone? Is the elbow unstable? And who is your patient?
Let's end with one final question to really make this stick. You have a patient with a completely shattered radial head and a very unstable elbow. What is the one surgical option that is totally off the table? And what's the disastrous biomechanical consequence if you make that mistake? Have a think about it. The answer really captures the most important lesson we've covered today.